Hello, I'd like to talk about how I, as an orthogeriatrician, approach the issue of falls. And as in many of my teaching exercises, I'll start by giving you a vignette of a typical patient, and this is not a real patient, this is an average of the sort of patients that I might see coming in with a broken hip. So somebody with cognitive impairment and some vascular comorbidity. She's 82. She was found on floor at home. Her history is very limited. She seemed confused to the orthopedic surgeons who were briefly clerking her in. An inadequate clerking heading towards orthopedic surgery as the prospect, and little thought given to what might be done to try and prevent her falling again. So we need, when we're looking after this sort of person, to develop protocols to allow the admitting doctors to understand what they should be looking for and how they might be responding to that, and for the whole of the MDT to think about how they might address this lady's obvious risk of falls. Risk of falling is subject of an enormous number of papers in the literature. It's very easy to take a group of people who've fallen over and to compare them with people who haven't fallen over and to notice that they're two completely different groups. This is largely, I think, an exercise in comparing apples and oranges, but it does identify some areas that are obvious weaknesses in the falling population, the sort of patients I see with hip fracture. It doesn't necessarily take us towards why that individual fell over, or indeed identify things that we can do something about. So not really a terribly useful literature. A simpler approach was one we took in Cardiff some years ago, which was to simply log why people fell over. And though while we're at medical school we have enormous amount of time spent learning about arrhythmias and epilepsy and other serious medical conditions that can lead to blackouts and syncope, the causation of falls, when you really take this history carefully, is rarely directly due to a simple medical problem. The vast majority of patients fall over because they can't walk very well, or they trip over something, or both. Or we're not quite sure because their ability to give a history is unreliable with background cognitive impairment. If we're going to try and do something about falls, you want to think about the literature, and if you're trying to find effective treatments in the literature, Cochrane is always the place to start. There's a lot in the Cochrane reviews. This is some years ago, and if we look now at what was found in the Cochrane reviews, there are a whole range of things that might be effective as interventions that might be appropriate for patients if we're trying to prevent falls. Within those, one trial I'd like to highlight is Rowan Harwood's beautiful study where he took people on the cataract waiting list, and if he expedited cataract surgery there were fewer falls and specifically fewer fractures in the operated group. So making sure that your patient has cataract surgery if appropriate does seem to be an effective intervention. When the first NICE guidance on prevention of falls was being written, this paper was hugely powerful. Jackie Close ran a randomized control trial, the PROFIT trial, seeing patients attending casualty with a fall, and they had a medical assessment by her, and then an occupational therapy home visit. And that randomization to that as opposed to usual ED care proved very effective in reducing the risk of patients returning with further falls. It was influential in the national guidance that was written at that time. And within the NICE guidance there is this emphasis on multifactorial assessment, trying to find all the things that might be wrong with people. This is comprehensive geriatric assessment, but identifying all of the elements that might play a part in the risk of somebody having a fall, and then looking at multifactorial intervention programs, trying to intervene to do something about those. And many services around the country have been set up, day hospitals, outpatients, falls clinics and that sort of thing are available as a way of trying to target risk of falls. And there are suggestions that these are effective. But the evidence is remarkably weak. There are small reductions, not necessarily statistically significant reductions in falls risks. But falls intervention is an expensive undertaking. Bringing somebody to hospital, perhaps using an ambulance to get them to a multidisciplinary team, and then they're being seen by a number of different people, cannot be a cheap intervention. And the cost effectiveness of these approaches does need to be borne in mind. Not least because when you try and pull together the whole of the literature on all of the interventions, the multifactorial interventions that have been put in, and this is a lovely piece of work by Sally Lamb's group, where they looked at all of the trials that are out there and showed really a very modest reduction in the number of fallers across those trials, and a non-significant, very modest reduction. So can't be terribly convinced by that. And within this analysis, they found no real impact on admissions, A&E attendance, death, and there were insufficient data to look at falls and injury rates, which is of course what I'd be more concerned about, trying to prevent somebody coming back with a further fracture. So it's a bit disappointing. Somebody needs to run a really big trial looking at fracture prevention as the end point of falls interventions. So of course Sally has. This is a beautiful, I think, definitive study, the PREFIT study, where she randomised at-risk community patients, people living in the community who were identified as being at risk of falls. And she randomised them to essentially a placebo arm of having a postal advice, to a falls risk screening and then targeted strength and balance exercise work, or to falls risk screening and then a multifactorial intervention. And her study failed to show any advantage of either of those two active arms in that trial in terms of reduction of falls-related fractures, which is all very disappointing. And it leaves us in a little bit of a quandary as to what do we do for this lady. So how should we approach this lady? My approach to her is to think through some of the areas that were highlighted in the trials I've just shown you. She's lying with us. She's not immediately a candidate for cataract surgery, and in my experience, most of the patients who we see coming in with a hip fracture, if they have cataracts, they've already been assessed for those. What we need to be thinking about is the complexity of her as an individual and trying to pull together elements of management for her. The first thing I do when I see a new patient with a hip fracture is to take a history. I think taking the history of the fall is a great way of letting your patient talk to you, let them give an account of you, and while they're giving that account of you, you're starting your comprehensive geriatric assessment. You're identifying their difficulties with communication, memory, speech, hearing. You're identifying whether they're paying attention, whether they're able to put together a sentence. You're looking at their mood, their morale, their degree of anxiety and fear in what is a horribly stressful situation. But you're also developing a rapport with them. You're showing that you're interested in them as an individual. You're not trying to rattle through a list of things I need to do to get this lady ready for theatre. And when you're taking that history, letting the patient flow the history to you, give the full story of what happened, listening for clues to suggest that there may have been a medical or a neurological or cardiological event that was precipitating it. Asking about previous falls, trying to identify people who are having uncertainty as to quite why they fell. They don't clearly remember that I tripped over the door sill as I went in. I was tripped over something. There was a specific problem, or I was a bit weak on my leg, or my poor knee let me down. People who can't give that story, getting more concerned as to whether there might be some sort of underlying medical causation for that individual. You only get this chance to take this history when you see people right at the beginning of their time coming through the system. After a while, people have told the story so often that they get bored, or indeed, if they're nervous that they can't really remember what happened, they start making up an explanation for themselves to boost their own self-confidence and to deal with some of their own anxiety. So that I can't remember why I fell. Well, I must have tripped. And by the time the fifth person asks them their story, yes, well, I tripped. And often that story is then not pursued, even though there was real uncertainty as to why this lady found herself on the floor. So let the patient give you a detailed history and start thinking. But as with much of geriatric medicine, when you're taking a history, you need to be thinking about what are the potential interventions that I need to be identifying. For many of the interventions I've talked about in the previous trial just aren't going to be relevant. So strength and balance classes out in a sports centre to try and improve health and fitness is clearly not going to be something we should be targeting towards. And we're left with a relatively short list of things that we can be doing. When I'm talking to her, I tend to have her drug chart in my hand. And review of her medication is hugely important. We know that polypharmacy is associated with falls risk. We know that a number of drugs are associated with falls risk. We haven't got good evidence that crossing off individual drugs and reducing the total number of drugs will make a difference. But it's a logical and sensible way to be working. And I think every ward round that I see with every patient, I'm looking to see if there's an opportunity to remove drugs that might reduce blood pressure or affect cognition or cerebral function in a way that might lead to falls risk. So reviewing neurological medications, Parkinson's medications, and all the anticholinergic drugs, the overtly anticholinergic drugs that people might be on, and then other drugs that have an anticholinergic burden associated with them. There's an opportunity when people are in hospital to do that that's often not there for their GP. It's difficult for a GP when seeing somebody who seems to be ticking along okay to say, oh, let's try you off this and this and this. Whereas in hospital we can hold drugs for 2 days, 3 days, a week, cross them off altogether and work with the patient over the time that follows to see whether those drugs were really necessary. So we'll look at antipsychotics, we'll look at antidepressant therapy, look at anti-epileptic therapy, get rid of all-night sedation if it's at all possible, and review people's Parkinson's drugs. In terms of cardiac medication, there's a lot of opportunity to review things. Managing blood pressure in the context of this lady is very difficult. We should be doing lying and standing blood pressure, but if I try and do lying and standing blood pressure on her now, I won't find a drop because she's too painful to try and get up. I'll get a false negative. If I do it in a couple of days' time when she's had surgery, I will get a postural drop because she'll be hypovolemic after surgery. I'll get a false positive. And a test with a false negative and a false positive rate like that is not going to be any use to me. So I can't really be looking at her lying standing blood pressure at this point in her assessment. I might say let's leave it until later in her stay, but there's a real risk that it gets forgotten or missed amidst the hurry towards getting people home. So I think it's important to look at lying standing blood pressure as a theoretical exercise. And my approach is to say, let's get rid of anything that might cause postural hypotension, even if I'm not sure that she's got it. She's going to have postural hypotension tomorrow after surgery. So that's an opportunity for us to cross off some drugs or to miss out some drugs and then only add them back in again if there's good evidence for them. And from the cardiac medications, you will find people who are on furosemide, on diuretics for previous ankle swelling or heart failure, who are no longer fluid overloaded and whom their omission and careful adjustment is worth looking at. There are people on antihypertensives, thiazides may be worth holding for a while. Calcium channel blockers, definitely a drug worth omitting in the perioperative period because it'll exacerbate the risk of postural hypertension while this lady's trying to get back up after theatre, but it'll also worsen hypotension and the risk of acute kidney injury and delirium during her time in theatre. So perhaps miss it out on the morning of theatre, the morning after, and then think about it afterwards. ACE inhibitors and ARBs are drugs that we stop when people first present with a hip fracture, and only reintroduce when we're comfortable that their blood pressure and their renal function have recovered from the stress of the injury and surgery. Beta blockers, I think, are a little bit more difficult. If you stop beta blockers, people will have an adrenaline surge to accompany the one that's normal in this sort of stress situation of surgery and injury. And the risk of precipitating fast atrial fibrillation or an arrhythmia or indeed angina is significant. Nitrates, I tend to try and get rid of. Most people who are on isosorbide mononitrate as an anti-anginal treatment, in my experience, haven't had an angina attack for ages, but their GP may be nervous about stopping it. Well, if they haven't had an angina attack by the time I talk to them following a period on the floor and the horrors of the injury that they've suffered, they're not likely to have one. And certainly if people have gone through surgery without having an angina attack, that's an opportunity for us to remove the isosorbide, make sure that GTN is available, but to try and get rid of that as a drug. Alpha blockers are a terribly powerful cause of postural hypotension, and the difficulty there is really confined to men. Stopping alpha blockers in men can very easily precipitate urinary retention, so we need to be a little bit cautious about removing alpha blockers in men where there's a story of prostatism in the perioperative period, because a catheter hugely complicates post-operative management for somebody. So there's a range of things that one can be doing and that we normally do routinely. And thinking about people's blood pressure intelligently, thinking about what it should be today, how it's going to behave today, and then looking at it on a day-by-day basis allows you to optimize their drug chart over the time that you're working with them in their recovery. The other interventions that are out there from the literature are less easy to apply in this lady. But she does need us to try and get her back onto her feet. Physiotherapy needs to continue over the time that she's restored to walking on the ward. But in practice, most people leave hospital as soon as they're able to walk a relatively limited distance with a walking frame. That's really not reduced her risk of future falls. It's not really managed her risk of future falls. If anything, it's increased her risk of future falls. But she's going home at that point. And what we need to be sure is that the process of physiotherapy works with her until she's confident and safe on her feet and managing well. So community physiotherapy is a real challenge, making sure that continues for as long as the patient's really benefiting from it. And occupational therapists, very good evidence that an occupational therapist visiting the house, working with the patient in the house to adapt the environment, to make the environment safer, is a sensible thing to do. And nowadays, most of our patients will be going home and meeting an occupational therapist on their arrival at home so that those sort of changes can be implemented. So my approach for this lady is that good rehabilitation is the same as good falls management. We try and take a history, we look out for things that might be causing a problem, think about the cardiac blood pressure implications of the drug chart, and then make a rational attempt to try and minimize medication for them. We only chase medical causes if there's a really convincing history. There's very good evidence that doing a Holter monitor, a 24-hour ECG monitor on somebody simply because they've fallen over without very good ECG or history evidence for an arrhythmia will identify problems, but it won't necessarily identify the problem that caused this person to trip over in the first place. It'd be very easy to over-investigate people and find asymptomatic, non-pathological abnormalities on a 24-hour tape that lead you to prescribing rather than revising medication. Make sure that people have a home safety assessment when they go home, and don't stop rehabilitation simply because somebody's been discharged. Does that all work, though? I do that all day, every day. I don't see a patient without thinking about falls management and drug reviews. But am I really making a difference to their risk of falling? I think this is a really important issue, and if you look back at the trial evidence in the literature, there's a real challenge that these wonderful, obvious, sensible things that we're doing don't seem to make a difference to people's risk of falling. Why is that? Why have all these trials essentially failed to show a benefit of falls prevention? And the answer to that, I think, is because they're trials and they have patients in them. And if I take this lady and rehabilitate her well, and my team, the OT, the physios work well with her, the pharmacist looks at her drug chart, we do everything right, she'll go home active and have a good quality of life. And she'll fall over when she's out doing something. If we don't do all of this falls prevention, we don't do good rehabilitation, she might not get home, she might go to a care home, or she might go home and be frightened to be up and about. And there's this direct parallel in what people do with how confident they feel on their feet that we all face. And I'm tired of people telling me that 1 in 3 over 65-year-olds falls every year, because I know that 1 in 3 under 65-year-olds also falls every year. Age doesn't bring you a risk of falling. Gravity causes falling. And we live a life that's constrained by our fear of falling. And falls management is not about preventing falls. It's about preventing fear of falls and falls leading to damage to patients, damage to quality of life, and to injuries. And as a result, what we're trying to achieve for our patients is not to prevent them having falls. We mustn't set up services that are funded simply because they can prevent falls, because they will fail. No service is going to stop people falling over. What we're doing is improving people's quality of life after the catastrophe of a hip fracture. And obviously, the way to prevent people having a serious injury as a result of a fall is to manage osteoporosis. But that's another topic. Thanks.